I just wanted to thank everyone for joining us today for the latest in our Health Tech webinar series. I'm Cassie Walker, and I'm a program director here at the AHA Center for Health Tech and Innovation. As I mentioned, we are recording this webinar. So we're excited today to welcome the founder and CEO of Bioformus, Dr. Kuldeep Singh Rajput, to join us here to talk about the tremendous trajectory of Bioformus, including how his company works with the AHA and why the collaboration is important for both of our organizations. But before we dive into that, let's do some quick introductions. First, a little more about me. I serve as the marketing communications lead for the Center for Health Tech. So I work closely with companies like Bioformus on marketing and publicity opportunities that benefit both organizations. And I'm also, like most people at the AHA, I wear several hats. I'm also the program director for a standalone program here at the center called Doctors with Heart. And it's a new program. We just launched it last year, and it provides doctor-to-doctor cardiovascular consultations between our AHA member cardiologists who volunteer their time to discuss patient cases with clinicians in federally qualified health centers and community clinics. So it's a doctor-to-doctor consultation model. And these clinics, they serve generally under-resourced communities. So we connect the two doctors via a telemedicine platform. And I'm going to give you a little more detail on that program here in a few minutes. But for now, I'd like to ask my team to introduce themselves. I'm joined here by a couple of members of my team. We've got Dean Mitchell, our business development lead on. Dean, would you like to introduce yourself?
Hey, Cassie, thanks. Here, but I'm glad to going on with Bioformus today. Near dear to our heart. As the business development lead or strategic business lead here at the center, I'm privileged to work with companies around the world. Talked with Germany, I guess, this morning. We talked with a company in Canada yesterday, and Israel last week. So, and obviously all of the United States, we are talking with innovative companies that are working in several different fronts. The science of the AHA, foremost. Looking at closely companies that are in the mobile health space, digital therapeutics, anything to do with HIT, health information technology, devices and sensors and wearables are just exploding in the marketplace right now. Anything that we can do to personalize the healthcare of the individual patient with the science of the AHA. It could be in telehealth. As you know, we're talking with companies in artificial intelligence, voice applications, various apps and data. So we have been laboring to get together and collectively to develop this consortium of where small companies, bootstrapping all the way up to the multi-billion-dollar international companies, and kind of cross-pollinate in ideas and solutions to make healthcare more personal to the patient and bringing together thinkers and scientists and technical leads from around the world. So, you know, that's kind of my role is bringing these companies together with you and creating an environment where we can all excel in personalizing this healthcare for the individual patient.
Very nice. Thank you, Dean. We're also joined by Dr. Pat Dunn, also a program director here at the center, who's worked very closely with Bioformus over the past year or two to bring this relationship to life. Dr. Dunn, would you like to go ahead and introduce yourself?
Sure. Thanks, Cassie, and thanks, Dean. So as Cassie said, my role, I'm the program director for Connected Health for the Center for Health Tech and Innovation. My background is in cardiac rehab. I was a clinical exercise physiologist as well as a program director, and I've worked in both hospital and physician practice. I've worked in for-profit and not-for-profit. I've worked in corporate settings as well as startups. So I've literally seen it all the good, the bad, and the ugly. But my interest really is in how can technology help to solve problems encountered in healthcare. and especially on the patient level and the consumer level, do they actually understand the information, and can they act on that information? And for the providers, again, does that information translate into better health outcomes for our entire healthcare system? So I call that health literacy, and in this context, digital health literacy.
Thank you, Dr. Dunn. We also have Darcy Barrett here behind the scenes helping us to run everything. So thank you, Darcy. And of course, a special thank you to Dr. Rajput, the founder and CEO of Bioformus. Thank you for joining us today, Dr. Rajput. Would you mind introducing yourself as well?
Yep, absolutely. Thanks, Casey. Hi, everyone. I'm Kuldeep, founder CEO of Bioformus. I started the company in 2015, and Bioformus really started with a dream, and the dream was, can we predict disease before it happens so that we can improve health and outcomes? As you know, every one of us knows a loved one, directly, indirectly, who has suffered from a complex chronic condition. Would it be really beneficial if we could have predicted that earlier? And that's what has really driven us for all these years. So what we do at Bioformus, really is we use our data platform to build virtual care models for managing patients remotely. And that includes the entire transition care from acute to post-acute to long-term chronic care. And the entire goal of Bioformus has always been, how do we improve patient outcomes, minimize the cost and burden of care by really focusing on delivering a personalized intervention to the right patient at the right time.
Yes, that's great. Thank you so much. So for today's session, we'd like to start with an overview of the Center for Health Tech, followed by the same for Bioformus, to give everyone kind of the lay of the land, really a baseline of understanding of the two organizations for some context. And then from there, Dr. Dunn and Dr. Rajput will have a conversation about our collaboration and also where things are headed. So along the way, please do feel free to add questions into the chat. I'll be monitoring that, and we're happy to tackle the questions as they come up. I'm sure Dean and Darcy will also be including questions for you guys as well. So we'll also allow time at the end to make sure that we catch any that got by us along the way, along with any other final questions. So that's the format for today. So let's start with the Center for Health Technology. Dr. Dunn, are you ready to kick us off?
I am ready. So first of all, thank you, Kuldeep, for joining us. It's truly an honor. And Bioformus was one of the original members of our Center for Health Technology and Innovation. So I want to give a little bit of background on that before we dive deeper. So the mission of our center is to be a connector into the world of technology and to be a leader in how scientific guidelines and research are translated into actionable steps that can be taken by patients and consumers, as well as healthcare providers and professionals. So I really have a fun job because I get to connect with both technology leaders like Kuldeep, but also clinical and scientific minds, really the best of the best in both of these areas. I've seen over the years a better commitment to science, which is really key. I mean, we see amazing technologies and really to help make those science-based. But we still have challenges. We have challenges in getting this technology into the hands of the people who need it the most, both on the patient side, but also the frontline healthcare providers who really can then help move the needle on health outcomes. And frankly, this includes everybody. This includes people, not only people who can afford expensive gadgets. So using the full realm of technology. So imagine learning that you know a person, a loved one who has cardiovascular disease, or maybe they've been impacted by COVID now, and they're at greater risk for a bad health outcome, maybe due to social factors, or maybe even to lack of access to care. Frankly, the pandemic has just magnified this issue. There's a lot of people that can't or won't, seek care due to health risks. And so technology then can serve as a lifeline to many of these people in a way that really wasn't available to them before. So we're going to talk about two strategies. I'm going to talk about two strategies, and Cassie's going to talk about a third, about how we do that. First is what we call our Innovators Network, and the second is what we call our Intelligent Health Solutions. So our mission at the American Heart Association is to be a relentless force for helping people achieve longer and healthier lives. There are some amazing technologies out there, and certainly there are many needs that healthcare technologies can solve. It's frankly a very target-rich environment. There's multiple conditions, from hypertension to heart failure to atrial fibrillation to digital cardiac rehab. There's multiple technologies, artificial intelligence, telemedicine, remote patient monitoring. Part of our role is to kind of help serve as a matchmaker, aligning the technologies with the needs. And again, our role is to help the tech world achieve a basic promise that technology can actually move the needle on health outcomes for people. So this really is a translation from printed guidelines that are written by academics and printed into medical journals. How do we translate into something that's actionable, both for the people using the technologies, the patients and consumers, and the clinicians, in a way that can be meaningful to both groups? So we start with what we call our Innovators Network. That's really the first step. It's a group of technology companies. Some of these are listed. Bioformus is an example. There's others, Livongo, Lifecore, Happify, Fitbit has recently joined. So what we do, we participate in a lot of events. We have, back in the olden days when we had actual live events, we had a health innovation pavilion at our scientific sessions. Now many of those events are virtual. But we still conduct those events. We're doing today with a webinar. We also are very involved in research, both from helping the technology companies design the research, and in some cases actually helping them to execute on that research. And also, again, really having a good, strong science background for this. Again, so that the amazing technology can achieve all of the things that we're hoping that it can do. The program that I run is called Intelligent Health Solutions. In the past, we've called these care plans. These are plans of action around 10 cardiovascular conditions. The first one we created is in heart failure, and we've worked with Bioformus. I know they have a strong track record in heart failure. We have plans in cardiac rehab, stroke, atrial fibrillation, as well as ones that are more on the prevention side for hypertension, diabetes, cardiometabolic, even a program for childhood obesity. And this is an accumulation of content assets, videos, articles, all created by the American Heart Association and put into a structure that hopefully makes sense for people. So they're sequenced in a way that people can benefit. And they're sequenced in multiple ways based on both their condition, so around something like heart failure, but even around their other factors that are important, including their personality factors. So how proactive or reactive are they? Do they have goals and a plan? And really trying to help them make sense of this in a most meaningful way. So I'm going to turn it back to Cassie, and she's going to tell you about a third program that we've been working very hard on, and Cassie especially has been working hard on, which is called Doctors with Heart.
As I mentioned in my introduction, the program director for Doctors with Heart, a program that we just launched last year in 2020. And, it's really, it's a program that's important. It's also near and dear to my heart because, here at the AHA, our mission is to help people live longer, healthier lives. But people in under-resourced communities do tend to be at highest risk for cardiovascular disease. So, you can put yourself in someone's shoes who is told they have some sort of heart disease. and yet they live 100 miles from the nearest cardiologist, or they don't have insurance, and so even a nearby cardiologist is out of reach. And so they might worry that their lives will be shortened, and they wonder what they're going to be able to do and what their life will look like going forward. And this is the communities, these are the communities that Doctors with Heart is designed to help bridge the gap. So this is how it works. It's a pretty simple model. On the bottom right, you see there the clinical cardiologists who are AHA members, professional members, who are active cardiologists, and they volunteer their time to provide consultations to doctors who work in federally qualified health centers and community clinics in underserved areas. And we connect them via a telemedicine platform. And you know, when we first envisioned this program, it was about a year and a half ago, maybe 2 years ago now. Telemedicine was not a term that everyone knew or had even experienced. And of course now it's a whole new world. So we're fortunate to work with a leader in the field, Amwell, to provide us our telemedicine platform. And it just makes it easy. You know, it's pretty, for patients, they usually don't even know that the doctors are having this consultation, but it's easy for primary care physicians and for cardiologists to get on the phone and talk. So great successes so far, and we're continuing the program now into 2021. And really what it does, you know, from an AHA perspective, some of the things we're very focused on, this program is great to achieve those things, such as ensuring equitable health for all. It's a primary focus of the AHA for 2021. And we're meeting people where they are, you know, through their primary care physicians in these clinics. It also allows for skills-based volunteering for our AHA volunteers. So they, you know, these clinical cardiologists, it lets them volunteer by doing what they do, cardiology, all with the goal of increasing healthy life expectancy. So I'm happy to, you know, field questions. I'll put my email address in the chat. We'll also give you the CHTI general email address, which comes to all of us as well. So if you have any questions on this, you know, please feel free to ask. And I'm going to pause here. It looks like we have had a question come in. What does engagement between the Center of Health Tech and early stage pre-regulatory approval startups look like? So, Pat, can you tackle that question?
Yeah, and maybe I can ask Dean to follow up maybe through chat and through email with the question. Dean Mitchell is our business development lead. We can certainly do that, but basically, you know, the initial way is for companies to join our center and become part of this network. Maybe if Dean or Darcy can put in the link to our website, it'll provide that. It actually shows the list of the companies. But then also we can create a contact point there, without getting into too many details on the logistics.
And I think it's one of the benefits of the way that we work with companies. It's meant to be very flexible and based on the needs of both organizations. So, okay, and I just put my email address in our general CHTI email address in the chat for you. Okay, so let's move on. For Bioformus, Dr. Rajput, are you ready to walk us through here?
Yep, absolutely. All right. Can you guys see my screen?
Yep, looks good.
Perfect. All right, so I think you know, what I'm going to walk through is very briefly about the company, and maybe you know, talk about our heart failure initiative, which we have you know, built and now scaling quite rapidly in the US, and certainly the partnership you know, and support from AHA. So for those who don't know about Bioformus, very briefly, you know, as I was mentioning, we are a global tech-enabled healthcare company, which really is on a mission of improving patient outcomes, minimizing the cost and the burden of care by focusing on delivering precise intervention to the patients at the right time. Very high-level facts of the company: 250 plus employees, headquartered in Boston, offices in Singapore, Zurich, India, raised close to 145 million in venture financing. What we have done over the past 4 to 5 years is built this huge data lake of over 4.5 million patients' data, all captured in an ambulatory setting using sensors and companion app, and really layering that with actual clinical data, which enables us to look at new novel digital endpoints, predictive algorithms, etc. Strong patent portfolio, and we work with a variety of customers ranging from pharma to large hospital systems and payers. And over the past 1 year, we acquired 3 companies: a wearable sensor company, a digital therapeutics company focused on oncology, and a software development vendor. So to give everyone a better understanding into our business verticals, as a company, we have 2 models or 2 verticals. One, what we call as Bioformus Health, which really focuses on virtual care models to manage patients remotely. And that involves how do you transition a patient all the way from acute to post-acute to long-term chronic care. And the second one is primarily digital therapeutics, which we call as Bioformus Therapeutics, where we build monotherapies or combination therapies with a pharma partner along with a drug portfolio. So both of these business verticals are really powered by our single modular platform, what we call as BioVitals. And to give you a better understanding, I break BioVitals platform into 3 main key pillars, starting with the patient-facing tools. And the patient-facing tools really focuses on how do we capture data from patients passively. We don't want to be flooding patients with 4 or 5 different devices, but how do you focus on single sensor which continuously captures multiple parameters from patients passively with a great user experience. And of course, the active data capture involves a patient-facing companion app, which really enables them to interact, engage in the program, and capture the right contextual information or contextual data. All this information would then go to our second pillar, which is our analytics platform. And the analytics platform really, again, focuses on how do we move from really being reactive to more proactive. And if you look at, the way I like to position it is, it does 2 things. One is it has the ability to take all of these data and really have the ability to predict decompensation or complications in patients ahead of time. And once you do that, the question really becomes, what do you do next? Because one of the biggest challenges, in digital health or remote monitoring has been you're overwhelming clinicians with all of these data and alerts, but clinicians don't know what to do with it. So really focusing on, evidence-based clinical intervention by building, automated care, protocols or treatment algorithms, which eventually get integrated into the clinical workflow, but also enables an intervention. And all of this data is finally, displayed on a clinician-facing dashboard, as well as a nurse dashboard to enable them to, care for the patients. So to illustrate this, I'll probably take heart failure as an example. And if you look at heart failure in the US, as you know, #1 cause for hospitalization in patients over 65. But one of the biggest clinical unmet need is that less than 1% of patients with heart failure are on optimal target dosage, and less than 20% of these patients receive guideline-directed medication therapy. And this was proven and shown, in the CHAMP-HF registry trial. And that eventually results in 1 in 4 patients coming back into the hospital within 30 days. So we built, BioVitals HF, and it's a turnkey platform which really enables to early detect exacerbation, engage patients virtually, and of course offer this entire remote treatment and optimization of medication to drive better outcomes in patients. The way we structure the program is a 90 days program. Once the patient is onboarded, especially patients with half-ref, class 2 and class 3, they get onboarded, using a wearable sensor, what we call as Averion, which they wear on their upper arm, and the patient gets a patient-facing companion app. The patient continuously starts leveraging the sensor to capture, almost 10 different parameters, all the way from heart rate variability, respiration rate, temperature, blood pulse wave, different activity-related biomarkers, sleep analysis, etc. Along with that, the patient continuously, is managing their medication. They get education content, which is using the care pathways from AHA, as well as we have, leveraged these passively captured data to continuously, drive engagement in patients. Rather than having, patients look at all the content and education on a daily basis, we try to take it to a next level of how do you personalize behavior change of education and content. So, let's just say if a patient is lying down and sleeping, at a certain angle rather than sleeping flat, we know that the patient is having 2 to 3 pillows. And at the same time, if the patient has shortness of breath or heart rate elevation, we know that the patient is congested. So really having the ability to push content associated with that contextual event is how we have leveraged AHA science and content and clinical guidelines to engage the patient. But apart from that, based on all the data being captured, we also automatically provide clinicians the ability to remotely optimize dosage and therapy in patients. Leveraging AHA guidelines for heart failure, guideline directed medication therapy. We up titrate, down titrate, switch medication so that the patients are on right optimal dosage. So to summarize this entire thing, there are a few key value propositions, starting with continuous monitoring using single sensor with a great user experience to capture continuous multivariate physiology signals, leveraging that, having an ability to early detect complication and eventually having the ability to, optimize dosage and therapy, and eventually integrating that into the clinical care pathways. And as you know, there is a very rich science, which really has demonstrated that this model really works. And one of the studies, which was actually published in JAMA Cardiology, had patients remotely monitor with a team of navigators, which included pharmacists, nurse practitioners, and heart failure cardiologists who were actually making clinical decisions depending on the treatment algorithms and the recommendation. And as the study demonstrated, patients who were on the remote GDMT optimization group had a significantly greater increase in baseline in utilization of all categories of guideline-directed medication therapy. And also, the patients which advanced to the target dosage was higher as compared to standard of care. So the science exists, the proof of concept exists, but ultimately it comes down to how are you actually delivering, this model and operationalizing this whole model. So we have built this end-to-end operational infrastructure, which not just has the technology platform, as you can see here, but also, has integration with EHRs, the bidirectional integration, the logistics, which involves shipping the kits to the patient, returning it back, the cleaning process, refurbishing it, etc. The patient support and engagement, which becomes very critical, especially in patients who are elderly and trying to, especially 70 years and above. It's important that a virtual team continuously engages with the patient, tracks compliance, tracks adherence and engagement, and provides any technical support around the clock. We have also put together a clinical care management, which involves a virtual team of physicians, nurse practitioners, heart failure cardiologists, who enable to intervene on any alerts, as well as care escalation as and when required. And finally, it comes down to how do you get paid for it. So really, having the entire reimbursement support associated with it to technically run such a program. And you can consider this entire program as, a virtual, GDMT heart failure clinic, which many hospital systems are now trying to set up so that there is better improvement in patients with heart failure. To actually summarize, heart failure was just one example, but as a company, we have been focusing on multiple disease areas, including COPD, asthma, arrhythmias, cardiac rehab, oncology. But again, the platform, what we have built is very modularized, has the right pieces together, which can be on top of which, you can layer in different clinical care pathways to meet that specific disease area. And just as an example, post-acute care was one of the things with heart failure, typically 90 days. But when it comes to acute care, we have even tested, the platform in acute care setting. And one of the studies which I wanted to highlight was, this hospital at home initiative where patients now are actually getting acute care in the comfort of their homes. And there was a big push, in December 2020, where CMS actually, approved that they would reimburse hospital systems to provide that acute level care in the comfort of patients' home, like they would do in an emergency room. And this study really demonstrates the economic benefit of it, where we were able to demonstrate almost 70% reduction in hospitalization, 40% reduction in overall cost of care, by managing these patients in the comfort of their home, but still being able to maintain that, safety and quality of care like they would do in an emergency room. So with that, I'll pause. I'll perhaps hand it over to Pat and the team. But thank you, and looking forward to the discussion.
Thank you, Dr. Rajput. We have had one question come through the chat, and then I have one, and then I'll turn it over to Pat. So the question from the chat from Bill: does the armband collect continuous ECG?
Yeah, that's a great question. The armband right now, it's an optical sensor. So it uses PPG to capture different physiological signals. We also have integrated different, ECG patches on our platform in case there is a need to collect continuous electrocardiogram. For example, the last study which I showed had a patch-based sensor in the study where we were capturing continuous electrocardiogram and using our algorithms to actually detect cardiac arrhythmias, which again, the whole system is approved by the FDA.
Great, thank you. And then my question was around the physicians and the dashboard and the pieces the physicians see. How has that been received, and what were some of the challenges you faced in incorporating that piece?
Yeah, no, I think that's a great question, and I think especially when we started to build our platform, initially it was just a dashboard for nurses, but again, clinicians were more comfortable to not just go through everything, but have a heart failure nurse actually manage the patient, triage the patient, and only escalate those patients who actually require clinicians' attentions to the clinicians. And we then, worked on building a mobile application for the clinicians. So clinicians, just with a couple of press of button on their smartphone, are now able to titrate medication or resolve any alert. So we have made it very simple for the clinician, rather than overburdening them with a lot of data. Really, focusing on those clinical information they would need to actually make a clinical decision. So I think what we have seen so far in a couple of studies, and also, as you might know, we work very closely with Novartis as one of our, of course, partners for heart failure, where we are now, especially when we look at multiple clinical studies or even commercial rollouts, our compliance rate, where clinicians are actually titrating medication, has been impressive. Clinicians are responding to alerts. The engagement level on resolving and taking an action on every recommendation provided has been over 95%.
That's amazing. Okay, thank you. One more question in the chat before I hand it over to you, Dr. Dunn. How is the system currently reimbursed in the U.S.?
Yeah, so I think, from a reimbursement perspective, I think there are different ways to look at it. When we are, offering this whole end-to-end care management, including our team of, clinicians who are managing the patients, our nurse practitioners, we use, traditional, remote patient monitoring, CPT codes to get, paid for the actual clinical services. There isn't a direct reimbursement for the technology itself, but right now we focus on, the clinical services and get paid for the clinical services. However, for some of the hospital systems we work with, they are actually getting paid for clinical services, but we get paid, as a software as a service or a subscription model by the hospital systems. So it really depends on who the customer is, because if it is a payer, we have different models. We work with them on a risk sharing or a value-based, outcomes model, especially with payers. So the reimbursements, how you get paid for it really depends. And as you might know, I think just a few weeks ago, there was also a new reimbursement pathway where those products or novel products which actually have a breakthrough designation by the FDA would actually get CMS reimbursement for first 4 years. And this is a big breakthrough for all digital health companies so that they can leverage on this new guidelines and potentially even get paid for the technology aspect of the solution.
Great, great. So we're having a few more questions come in, but why don't we hold those for just a minute because I want to give Dr. Dunn and Dr. Roche time to chat here for a few minutes, but we'll do our best to tackle all of these. So Dr. Dunn?
Okay, great. Well, first of all, Kuldeep, that was amazing. Can you tell us a little bit more about yourself? How did you get into this world of digital health tech?
Yeah, no, Pat, good question. I think, as you know, when I was back at MIT, there was this whole new proliferation happening in sensor technology, right? All these bulky sensors, what you put on patient's body, costed thousands of dollars, were costing, hundreds and tens of dollars, and soon getting commoditized, as you know. Huge amount of data, as well as there is very little value to the clinicians, and as well as the patients. Patients just don't know what to do with it. There's so many apps on the App Store, and there was this whole lack of legitimacy in data. And also, I think, our entire mission before I started the company was really about how can we leverage this passively collected data from patients to actually drive personalized intervention. And that involves moving from being reactive to being more proactive. So we started out as a data science focused company and gradually evolved building out our services, not just focusing on data science, but building out the end-to-end infrastructure, the clinical services, which was the progression we had over the past 4 to 5 years. But I think it really started with some of the work I was doing back at MIT and the interest really in digital health and the pain points what we are seeing.
Was it your original plan to start a multinational company?
Actually, when I started the company, I was ironically based out of Singapore. However, and I actually moved to Singapore because I came here to do my PhD, but quit my PhD 2015 when I started the company. But since the day we started the company, US was our focused market. And we knew that from day one, and we knew that we had to, relocate our headquarters at some time to the US. And we did so in 2019. We moved our headquarters to Boston. We still have a team globally, and I think it works out very well for us. There's either one of the office working 24/7.
Yeah, you have a great team. We've really enjoyed working with your team. So you've obviously done a great job of building a team and building a company. How did you hear about us, and what would you say is the value from your perspective of working with our Center for Health Tech and Innovation?
Yeah, no, I think Pat, we and the team have really enjoyed working with you and the team. I think there are multiple value what we see. The first, I think the care pathways, and the care plans, what you have put together, and over the past 2 years now, we have seen the evolution you have made in that, right? Where we were 2 years ago and where the care plans are, and the level of maturity and digitization it has today is completely different. And kudos to the work you have been doing. So I think really having rather than us going and building out content and education and those care pathways, how can we leverage what has been scientifically validated and what has worked, and that is the biggest value we see on how can we take the science and evidence from AHA, take what you have put together and customize it into our platform to actually drive care delivery. Of course, apart from that, I think AHA has a fantastic team of clinicians and experts who are experienced in digital health and running leveraging digital tools to better manage patients. I think that network also really helps, and in fact, as you might know, we got introduced through one of our advisors who is also works with AHA very closely, Malik Majmadar. Apart from that, I think, Pat, there is also a great opportunity on continuously looking at how can we enhance guidelines, right? Because if you look at current AHA or heart failure guidelines, for example, they're very static. Everyone just leverages one single set of guidelines, but there is a lot of evidence now coming out that medication or therapeutic intervention is going to be very personalized. How can we then take that to the next level and perhaps use passively capture data to personalize treatment rather than having one fit for all GDMT solution. So we really look forward to constantly working with you over the next few years on really advancing science and providing better care for patients.
Yeah, you just answered my next question, is what do you see the future holding? So it sounds like a lot of that. That's great. And I know we've all been impacted by the pandemic. I know your company's been also very involved in that. How has COVID and the pandemic in general impacted your business and your trajectory?
Yeah, I think even though it's unfortunate, COVID-19 really has been I would say a very positive for in general healthcare or digital health. I think as Casey was mentioning, telemedicine was not even heard of, and as you know, with COVID-19, there was a significant rise in telemedicine, remote monitoring adoption, and we were certainly fortunate enough to have managed over 50,000 plus patients suffered from COVID-19 or infected with COVID-19 over the past 1 year. We were commissioned by multiple governments And in fact, the publication will be out very soon, but we were able to demonstrate with our platform, the sensor and our analytics, that we were able to predict worsening, clinical worsening in COVID-19 patients who were infected with COVID-19 almost 21 hours in advance. And this, clinical worsening involves, requiring oxygen, ventilators, or even sometimes death. So I think that was really powerful. But apart from that, there were many other things we have been involved with. But in general, how do you monitor patients who are infected with COVID-19 in the isolation facilities or those who are quarantined? These are the two key applications which we were focused on. But our traditional business also expanded because in the US, as you might know, there are almost 45% of, there is 45% decline in hospital visits or emergency room visits. Even though patients have, actual acute event, they're still not going to the hospital, which is really scary. And, patients are expecting more personalized care. Patients are expecting care outside those four walls of hospital. And I think that trend is just going to, stay, and patients are not going to want to go back to the old way of how they were treated and managed, and really see how they can get more personalized care in the comfort of their home. And I think that's where, there has been a very positive movement. I personally think that the market has fast forwarded by at least 5 to 10 years.
That's great. I think we can go back and try to catch some of the additional questions in the chat.
So a question here, are you looking to expand the optical sensing beyond PPG to monitor a wider variety of biomarkers?
Yeah, so I think the armband currently involves, it has PPG, accelerometer, gyroscope, GSR sensor. Of course, we certainly are looking at adding new, sensor technology on the device. I think that will be in our pipeline. But I think given the current sensors on the device, we still have an opportunity to continuously keep, looking at new matrix. And one of the other things which we will soon introduce is, just using optical signal with other sensors, detecting AF burden, which, detecting sleep apnea episodes, which becomes important, especially, in patients with heart failure, for example, which are important comorbid conditions. But certainly, yes, we have a pipeline of, versions of devices which we are currently in development, and there will be certainly addition of new sensors.
Thank you. Okay, another question. What are the false positive rates for the Bioformus system?
Yeah, I think it really depends on how you quantify, the false positives, right? So I think on one part, on the predictive, I think we were able to show like a 2 weeks predictive window with an AUC of 0.92. In detecting heart failure exacerbation, before hospitalization or an emergency room visit. There are other things where we have sensitivity specificities for just a detection capability, like a cardiac arrhythmia, or detecting clinical episodes. So the false positive rates, I don't remember on top of my head for all of them, but as I was mentioning, especially for heart failure, we have demonstrated pretty good, AUC in detecting or predicting exacerbation in patients with heart failure.
Okay, great.
And it looks like we have one, we'll maybe call this the final question. Can you explain the difference between how Bioformus works with large systems versus small clinical practices?
Yeah, I think, if you look at the large health systems, right, and we work with, a number of large health systems, and it really depends on the maturity of the large health systems. Even though they are large, I would say at least 60 to 70% of these hospital systems whom we work with, they already have, let's say, a virtual care program set up, like a post-acute care or a RPM program, where they have their own team of clinicians, nurses who are managing patients. So primarily with large hospital systems, we are sort of a technology vendor to the hospital system, along with providing operational capabilities and leaving the clinical services to the large hospital systems. However, with small clinical practices, they primarily refer the patient to us, and we technically take over the entire care management of the patient. So we are a care management delivery, vendor or a partner, rather than just being a technology, vendor to this small clinical practice.
Well, thank you so much. This has been amazing. We really appreciate your time on this, and especially all the work you've done. You're literally saving lives.
Yeah.
And the capacity is to save even more lives. So thank you for all the wonderful work that you're doing.
Yeah, absolutely. Thanks, Pat.
And yes, definitely. Thank you so much. So just one last note for the attendees. If you'd like to speak with any of us here at the Center for Health Tech, you can feel free to reach out to us. We all get the email, chti@heart.org. And otherwise, just keep an eye out for our next webinar in our Health Tech series, which we're currently planning for the late April, early March timeframe. And if you haven't joined our email list, you can do so at ahahealthtech.org. All right, thanks again, Dr. Rajput, and everyone for joining. Take care, everyone.
Thanks, Casey.
Thank you. Yep.